Good evening, everyone. My name is Dr. Sherif Altoukhy. I'm a lecturer of cardiology at James University. Today we are going to have an interesting lecture, and it is like an interactive discussion about action potential antiarrhythmic medications. It would be presented in a different way because in this lecture we are presenting it in the form of MCQ questions, and we are going to discuss each question. So in order not to have like a long lecture about the medications, we are having them as MCQ. So let's have the first question. Would you please share the screen, Dr. Ahmed? Okay, so this is of course the classification that we know is the Vaughan-Williams classification for the antiarrhythmic medication, which we are all oriented off. Okay, but in the next slide we can see that in 2018 they have presented another classification for the antiarrhythmic medications, and these new classifications they have classified the other medications like the Johnson and the ivabradine in class 5. So would you please have next slide, Dr. Ahmed? So in 2018, they have released like a consensus about the antiarrhythmic medications. It's a very interesting consensus. And they have had another classification for the antiarrhythmic medications that can be shown in the next slide. And in this table, they can show us each one with its features, and they have much more details about a criteria of each one. So we are going to move, for the matter of time, to the questions, but of course, revise this consensus on the EHRA website or the AEC website regarding the antiarrhythmic medication. So we are moving rapidly to the first question in order to start our discussion. So can we move to the first MCQ question, Dr. Ahmed, please? So this is the first question. Regarding hypomagnesemia and hypokalemia, they cause prolongation of the QT interval by which one of these mechanisms? Increasing sodium influx during phase 0, increasing I2 current in phase 1, reducing calcium influx in phase 2, or reducing potassium influx in phase 3 of the action potential. So anyone have an opinion regarding this question? We all know that hypokalemia and hypomagnesemia prolong the QT by which mechanism of them? So I will move to the answer in order because I think it may be a difficult question. So let's move to the answer. So leave the next slide, Dr. Ahmed. Yes, it is reducing potassium efflux in phase 3 of the action potential, which is a repolarization. So if we see in the next slide, we can see the action potential, of course, in the atrial muscle fibers and ventricular muscle fibers. And if we see in phase 3, of course, is characterized by potassium efflux, which result in the return of the membrane potential to the resting state. The presence in next here, the presence of the extracellular magnesium and extracellular calcium, of course, help to stabilize the voltage-gated potassium channels in phase 3. So when there is can we move on back again, please? So when there is hypokalemia and hypomagnesemia, of course, this would reduce the potassium efflux and so prolong the repolarization phase, resulting in prolongation of QT interval. So that's how the hypokalemia and hypomagnesemia cause long QT. So let's move to the second question. This is an interesting question regarding ivabradine. All of the following are true regarding ivabradine except it acts on the funny current in SA node that allows sodium and potassium influx during phase 4 of the action potential. It should be taken after meals. It can cause luminous phenomena in 10 to 15% of patients that may affect vision. Its dose needs to be adjusted in patients with severe renal impairments. Anyone has an opinion regarding this question?
Can I answer, please?
I think the answer started to appear, yeah? So can we show the answer, Dr. Ahmed, please? Yes, of course. Here we are looking for the wrong answer or the wrong choice. Of course, ivabradine acts on the funny currents. This is, of course, a solid information that we all know in the SA node or the IF current. It should be taken after meals, that's true, and it can cause luminous phenomena in 10 to 15% till the end of this sentence. Yes, it is right. But affecting vision is not true. Luminous phenomena may be a disturbing side effect of ivabradine, but it doesn't affect vision. So, of course, that's wrong. And the dose needs to be adjusted in patients with severe retinal impairment. That's right. So, number 3 is the true or the answer of this question. So let's move to the other slide. And this is a summary of the action potential of SA node, AV node, which are called the calcium-dependent cells. And as we know, the sodium influx in the phase of slow spontaneous depolarization is responsible for this phase or the increase of the resting potential till it reaches the threshold. So when I give funny channel blockers, this of course reduces the slope of this phase, so reducing the heart rate. So let's move to the question number 3. If anyone have any question, of course, interrupt me and ask me, of course. This is like a summary of all the currents in the action potential. And this slide, of course, it was shown in the lecture that was shared to you in the group regarding the resting potential of SA node, resting potential of atrial and ventricular muscle fibers. So I move quickly in these slides because these slides are discussed in the original lecture. So let's move to the question number 3, please, Dr. Ahmed. Which of the following antiarrhythmic medication can be used in pre-excited AF? Procainamide, amiodarone, digoxin, propranolol. Would you please answer?
Procainamide.
Okay, that's right. So can you explain why? Can you explain why procainamide is used in pre-excited AF? So, okay, so let's show the answer. Let's show the answer, Dr. Ahmed. So the answer, of course, many answers question right. Which of the following medication can be used, of course, with procainamide, as you said? Procainamide, of course, is a class 1A antiarrhythmic medication, which, of course, slows down the conduction over the accessory pathway. So it can be used in pre-excited AF, in acute therapy, if the patient is hemodynamically stable. Also, flecainide can be used, but if the patient is hemodynamically unstable, of course, we give this shock. We cannot use amiodarone, although in the past it was used in pre-excited AF. But of course, it may slow down the AV nodal conduction, and also it may cause hypotension. That's why in the 2019 AC guidelines, they have put an issue regarding the management of pre-excited AF. And of course, in the next slide, we can see that in the flow chart, IV procainamide is one of the medications of choice together with flecainide in pre-excited AF when the patient is hemodynamically stable. So you can see it in the next slide, Dr. Ahmed. Yes, as we can see here, of course, procainamide and ibutilide, and also flecainide propafenone. But we cannot use amiodarone, and of course, we cannot use digoxin, beta blockers, or calcium channel blockers. So, of course, procainamide is the medication of choice. Okay, so which tachyarrhythmia should we avoid amiodarone? Of course, pre-excited AF. We should avoid amiodarone and long QT syndrome, because amiodarone, as it is a joker antiarrhythmic medication that can be used in many disorders, it can prolong the QT interval, so it is contraindicated in pre-excited AF and long QT syndrome. Let's move to the other question, number 4. Which of the following tachyarrhythmia doesn't respond to lidocaine? Ventricular tachycardia, PVCs, supraventricular tachycardia, ventricular fibrillation. Can anyone answer this question? Yes, the question started to appear. That's right. So the answer here, of course, is supraventricular tachycardia. Can we show the answer, please, Dr. Ahmed? So, of course, it is a peculiar in this choice because the other 3 are ventricular arrhythmias, whereas it is the only one that is supraventricular. The can see here that lidocaine is class 1B antiarrhythmic that is characterized by fast onset and offset of sodium channel inhibition. So in supraventricular arrhythmias, it is not effective as in ventricular arrhythmia due to this fast dissociation kinetics. So lidocaine is not a medication of choice in patients with SVT. We can use beta blockers, we can use calcium channel blockers, we can also use class 1C antiarrhythmic. So supraventricular tachycardia is the answer. Let's move to the other question, please, Dr. Ahmed. The antiarrhythmic effect of this medication can be accentuated with treadmill test. Sotalol, propafenone, amiodarone, mexilatine. Slightly difficult question, but it is very common in the MCQ exams and of course common in the MRSP exams. So what's the answer here? Yes, the answer started to appear. That's right. So can we show the answer, please, Dr. Ahmed? Propafenone, of course, it is the answer here. Propafenone plus 1C antiarrhythmic, as we can see in the next slide, that there is a famous phenomenon called the use dependence, which in this case, there is rate related or rate dependent increase in the inhibitory effect of this medication, which is class 1C antiarrhythmic with tachycardia. So with treadmill test, the complex started to increase in duration. So we can arrange treadmill test in the patients taking propafenone in order to check whether there is severe complex widening that needs to stop or reduce the dose. So propafenone show use dependence phenomena. Can we show the next slide, please, Dr. Ahmed? And then the next. The opposite to the use dependence is reverse use dependence, in which the effect or the inhibitory effect appear, of course, in resting state or in rate when the rate is controlled more than in tachycardia, and this is, of course, evident in class 3 antiarrhythmic medication like amiodarone. So use dependence and reverse use dependence are very important to understand in order to understand how to use the treadmill test in these patients and when to stop. Let's move to the next question. Here, I think it is an easy question. 53-year-old male patient with recurrent documented episodes of hemodynamically stable VT and is known to have ischemic LV dysfunction, ejection fraction 30, and it was decided that he needs an ICD. What is the best oral medication for him? Quinidine, amiodarone, sotalol, dofetilide. I think it is an easy question here, so we can show the answer. Here, Dr. Ahmed, please. Of course, amiodarone is the medication of choice here in patient who is scar-related VT. So you can see in the next slide that amiodarone, according to the guidelines, of course, which is a class 3 antiarrhythmic medication, can be used in structural heart disease in case of ventricular tachycardia, can be used also in VT storm with less side effect in the acute stage. Most of its side effects are cumulative side effect with a long-term use. So let's move to the next slide. So cumulative side effect, as we know, related to the skin, liver, lung, thyroid disorders, and corneal deposits. But of course, it has multiple use that leads that to nowadays we still, or so far we still use amiodarone in our clinical practice. Let's move to the next question, please. So, and then the next question, please, Dr. Ahmed. This patient, who is the same patient, is not responding enough to amiodarone and he's still having recurrent VT. What shall we add a medication for him? Dronidarone, ranolazine, propafenone, mexilatine. He's the same patient. So what do you think? Which medication can we add here? Can anyone try to answer here? Which one of them? That's right. Answers started to appear here. We can show the answer, Dr. Ahmed. Yes, that's right. Of course, mexiletine. Mexiletine has another terminology. We can show the next slide, please, Dr. Ahmed. Mexiletine sometimes is called the oral lidocaine. It is a class 1B antiarrhythmic that is very effective in ischemic VT, scar-related VT. But of course, amiodarone is the first choice before mexiletine. So we can use it when the patient is not responding enough to oral amiodarone at the time. We can give him mexiletine as an add-on therapy, but it is not the first choice except when amiodarone is contraindicated. And we should remind ourselves that class 1B antiarrhythmic shortens the QT. This question is an interesting question. All the following features characterize dronedarone from amiodarone. They are the same family, class 3 antiarrhythmics, which blocks the potassium channels, except it lacks most cumulative side effects of amiodarone. It had a fixed dose regimen. Its use is contraindicated in patients with LV dysfunction. Its use is contraindicated in patients with permanent AF. So we are looking for the false choice. Yes, answer started to appear. Yes, that's right. So can we show the answer here, Dr. Ahmed, please? That's right. Except contraindication is LV dysfunctional coronary disease. It is not an absolute contraindication. If we can move to the next slide, we know that dronedarone, of course, has the ATHENA trial, which shows statistically a reduction in all-cause mortality and cardiovascular hospitalization in patients with AF in order to maintain sinus rhythm. That's why it was favored in paroxysmal AF. But in the next slide, we can see here that the Andromeda trial and the other... Can we move to the next slide, please, Dr. Ahmed? The Andromeda trial and the Palace trial, of course, show increased mortality, especially in patients with severe heart failure. And Palace trial showed this in permanent AF, it increased rate of heart failure, stroke. That's why dronedarone, in the next slide, we can see that it is contraindicated in patients with NIHA class 4, 3, or 4 heart failure, or patient with ongoing myocardial ischemia. But if the patient has compensated heart failure, and you can see in the next slide, if the patient has compensated heart failure or is ischemic heart disease, but without any ongoing ischemia, I can use it. Also, it is contraindicated if it is combined with other QT prolonging medication because it prolongs the QT, or some enzymes inhibitors like non-DHP calcium channel blockers. It has a fixed dose, 400 milligram twice per day, and it has no iodine in its structure. That's why, of course, it doesn't have the cumulative side effects of amiodarone. Let's move to the next question, please, Dr. Ahmed. What's the beta blocker that has QT prolonging effect? Does anyone know which one of them? Thinks this is an easy question, of course. Let's show the answer, Dr. Ahmed, please. It is sotalol. Sotalol, of course, it is a special type of beta blocker. Sotalol, as we know from the next slide, is a racemic mixture of class 2 and class 3. Class 2 as beta blocker and class 3 as potassium channel blocker. That's why it is not an antihypertensive medication as other beta blockers, or not used in patients with just sinus tachycardia. We use it especially in patients with SVT like pre-excitation, and sometimes we can use it in patients with AF in order to maintain sinus rhythm. But the problem that it has a risk of QT prolongation, so avoid in long QT syndrome, avoid in LVH, and avoid in LV dysfunction. It can be used in ischemic heart disease, but in other disease, it is contraindicated. In the recent classification by the ATHENA, it classified sotalol as just class 3. So always sotalol is not an ordinary beta blocker. It is a class 3 antiarrhythmic which still has beta blockade effect. Let's move to the next question, please, Dr. Ahmed. Which medication can be used in Brugada syndrome who have multiple appropriate therapies episodes from ICD? Quinidine, adrenaline, flecainide, propranolol. So which one of them we can use in patients with ICD storm and Brugada? I think the answer started to appear right here. So can we show the answer, please, Dr. Ahmed? That's right. Quinidine, of course, is the answer here. We can show the next slide. Quinidine is class 1A antiarrhythmic that, of course, not commonly used due to many side effects. And remember from the undergraduate teaching that we have a side effect called synchronism, which is a type of toxicity caused by quinidine, but it is still can be used in Brugada syndrome. And we can show in the next slide, we can see that in the ASC guidelines, of course, they mention that quinidine can be used in Brugada syndrome as class 2A when they have electrical storm. So quinidine still can be used nowadays in patients with BT storm. Let's move to the next slide, please, Dr. Ahmed. This is, of course, a famous query about quinidine. How is quinidine is a sodium channel blocker, and despite this, it can be used in Brugada, although it blocks the sodium channels. The answer here is that it inhibits the potassium channel and decreasing the I2 current during phase 1, and so it lessens the attacks. So quinidine is not just an ordinary sodium channel blocker as ajmaline or flecainide, but it has an I2 current blocker effect, which reduces the episodes. So let's move to the next question, please, Dr. Ahmed. Let's move to the next question. Okay. Which of the following disease allow use of propafenone? Hypertensive patient with mild LVH, patient with effort angina and RCA lesion 70%, atrial flutter, patient with Wolff-Parkinson-White syndrome. So which of them we can use propafenone and it is not indicated? So the answer, can you show the answer, please, Dr. Ahmed? Of course, Wolff-Parkinson-White syndrome, we can use propafenone, and it is one of the most famous indications of propafenone, of course. So can we show in the next slide that propafenone is class 1C antiarrhythmic, contraindicated in all structural heart disease like LVH, ischemic heart disease, and heart failure. And also it is contraindicated in atrial flutter, because in atrial flutter, when it reduces the atrial rate, it may turn the conduction from 2 to 1 to 1 to 1. So paradoxically increasing the heart rate. So we cannot use it in atrial flutter except if combined with another beta blocker. So of course, remember the CASTO trial, which shows that which was prematurely stopped due to the increased risk of sudden cardiac death with flecainide. That's why flecainide cannot be used in structural heart disease and cannot be used in patient with epilepsy alone. So let's move to the next question, please, Dr. Ahmed. We just remind ourselves that class 1 antiarrhythmic act on the sodium channel, so they are sodium channel blockers. Class 2 are beta blockers acting on the beta receptors. Class 3 are potassium channel blockers acting on phase 3, and calcium channel blockers or class 4 act on the calcium channels, and then the miscellaneous class 5. All of the following are QT prolonging medication, except which one of them is not a QT prolonging medication?
لا الإجابة دي وين؟
So answer started to appear right here. Of course, it can show the answer, Dr. This linezolid. Lead, of course, is a famous glycopeptide antibiotic. Ciprofloxacin, of course, is a quinolone, so of course it prolongs the QT. Quetiapine is a famous agent that prolongs the QT, and clarithromycin, of course, is a macrolide, which is famous that it prolongs the QT. But linezolid is not one of them. Linezolid, of course, is the answers, and these slides, of course, we can move them rapidly, that remind us with the QT prolonging medication, and you can find them in the original lecture of antiarrhythmic medications. Antiarrhythmic is the best to be used in long QT type 3. Which of them can we use? Answers?
الإجابة
QT type 3.
الأولانية واحد.
So we can show the answer here, Dr. Ahmed, please. It is mixed. Long QT type 3, of course, is one of that special type of long QT syndrome that is characterized by gain of function mutation in the sodium channel, which lead to reactivation of sodium channels. So in this case, we need to use sodium channel blocker, which is a mixilitine, which is characterized by shortening the QT interval. So we can move to the next slide, please, Dr. Ahmed. We can see that long QT type 3 is not potassium channelopathy. The sodium channelopathy, mixilitine, of course, flecainide or ronozine may be considered as an add-on therapy to shorten the QT. So long QT type 3 is a different type of long QT syndrome. Let's move to the next question, please, Dr. Ahmed. These are the last two questions regarding amiodarone side effects. All of the following is true regarding amiodarone-induced side effect, except amiodarone can increase liver enzymes in up to 20% of patients. Pulmonary fibrosis caused by amiodarone may be reversible after discontinuation. Corneal deposit is a common side effect which may affect vision. Patients should be advised to avoid direct sun exposure. Which of them is false? So let's discuss each choice here. Amiodarone increased liver enzymes in up to 20% of patients. That's true. And in sometimes more than this, when it is used for a long time, it leads to some sort of hepatotoxicity. So it may increase liver enzymes. Pulmonary fibrosis caused by amiodarone may be reversible after discontinuation. That's right. Pulmonary fibrosis is reversible after you stop amiodarone. Corneal deposit is a common side effect. It is the most common side effect, but it doesn't affect vision. So it is false. Patients should be advised to avoid direct sun exposure, of course, because of the photosensitivity. So the answer, the wrong answer here is corneal deposits. Yes, it is the most common side effect, but it doesn't affect vision. Let's move to the last question in our lecture today. All of the following is true regarding the effect of amiodarone on the thyroid gland. Hypothyroidism is more common than thyrotoxicosis. Amiodarone-induced hypothyroidism may be followed by permanent damage and the need for long-term replacement therapy. Wolff-Chaikoff effect explains the hypothyroidism caused by amiodarone. Amiodarone may induce thyroiditis that shows elevated level of interleukin-6. This is a slightly difficult question. So what's the answer here or the wrong answer? This is a difficult question. That's why there is varieties or different answers. So let's explain each one. Hypothyroidism is more common than thyrotoxicosis. That's right. Hypothyroidism occurs in about 22%. Thyrotoxicosis in about 6 to 10%. So hypothyroidism of amiodarone, of course, is more common. Amiodarone-induced hypothyroidism may be followed by permanent damage. Yes, in patients with pre-existing structural heart disease like Hashimoto thyroiditis or pre-existing hypothyroidism, yes, amiodarone may induce significant hypothyroidism to the degree of permanent damage and needing long-term replacement therapy. Wolff-Chaikoff effect explains the hypothyroidism. It explains thyrotoxicosis. Wolff-Chaikoff effect explains type 1 thyrotoxicosis caused by amiodarone, whereas the Jod-Bezdo effect explains the hypothyroidism, which may occur sometimes in patients taking amiodarone. Amiodarone may induce thyroiditis that shows elevated level of interleukin-6. That's right. Type 2 amiodarone-induced thyroiditis, of course, is an inflammatory disease that is characterized by increased level of interleukins and cytokines, and it is the most severe type of amiodarone-induced thyrotoxicosis. Just at the start, it shows transient stage of thyrotoxicosis followed by permanent damage due to the thyroiditis. So this, of course, the answer here is number 3, Wolff-Chaikoff effect. So in the next slide, we can show like a summary regarding amiodarone-induced hypothyroidism and the explanation of the Wolff-Chaikoff effect. And the other slides, amiodarone-induced thyrotoxicosis, we can see that it is less common than the hypothyroidism. And there is type 1 Jod-Bezdo phenomenon, and type 2, of course, in patients with previously normal gland due to destructive thyroiditis. So by here, we have finished our lecture today regarding the antiarrhythmic medication. I'm sorry if I was rapid because of the matter of time. If anyone has any questions, of course, feel free to ask.